My name is Nefin Arıslan. Today, me and my group friends Mustafa, Ayça, Tuğçe, Kerem and Deniz will talk about the non-REM sleep arousal disorder. Here is our outline. And I will begin with the general definition and characteristic of the disorder. Before the definition, I want to define what parasomnia is. Parasomnia is a general term that is used for experience of dreams and movements in an abnormal way within the sleep duration of a person. And parasomnias are divided into two groups according to the period that they occur during the rapid eye movements or during the non-rapid eye movement according to Mahowald. Now I can move on to the definition of our disorder. According to Drakatas et al., a composition of disorders that are observed during slow wave sleep are named as the non-REM parasomnias, and they are considered to be unwanted behaviors as well as experiences. When we look at the definition of DSM-5, non-REM sleep disorders is defined as recurrent episodes of incomplete awakening from sleep, usually occurring during the first third of the major sleep episode and accompanied by either one of the following: sleepwalking or sleep terrors. And as psychology student, DSM definition is more useful for us, as you know. Now I have a video about the topic. Let's watch it.
Oh, freak. That's what you want to calm the fuck down. You're a liar. It's my house. It's good.
Yes, as you have seen in the video, sleepwalking is a phase that only some parts of the brain are awake. And during this phase, eyes of the person are open, but the person is not conscious. Therefore, patients developed an amnesia for this episode, and while sleepwalking, the individual has a blank staring face and she is relatively unresponsive to the communication coming from outside. Of course, therefore, it is very hard to awake those persons during sleepwalking. Now, let's look at two other videos now.
It's okay. Shh. Come on. Oh, baby. Oh, baby. It's okay. It's okay. Jacob.
One patient like him tied himself to the bedpost each night to prevent himself from attacking his wife. Evidence from a 1997 poll of over 4,000 people in Britain found that 2 in every 100 experienced some form of night violence.
As you have been watched, sleep terror experience is composed of screaming and extreme fear during sleep, usually beginning with a panicky scream without awakening. And besides this intense fear, there are also some signs of autonomic arousal, such as rapid breathing and sweating. Again, in early childhood period, as you can see in the baby video, sleep terror is significantly prevalent. Now, I continue with a recent study about topic from 2020. Besides the DSM-5 definition, Hepner and Nestor suggested that there could be two other subtypes of the non-REM related parasomnia rather than sleepwalking and sleep terror, and they are confusional arousal and sleep-related eating disorder respectively. In the first one, there is a confusion right after the deep sleep, and the second one, which is sleep-related eating disorder, patients demonstrate eating act without complete awakening from their sleep. Now, let's sum up with the main characteristics of the disorder. It can be said that there are 7 main characteristics. They are sleepwalking, sleep terror, sleep-related eating disorder, repeated actions of incomplete awakening, different responses or loss of responsiveness, and deficient dream cognition as a complete or partial amnesia of the episode experiences. Lastly, I want to mention an important note about the disorder. In order to define a disorder as non-REM sleep arousal disorder, different causes such as medication effect, substance effect, mental disorder, or specifically another sleep disorder should not exist in the person, as the International Classification of Sleep Disorders and DSM-5 stated. Now my friend Dennis will continue with further details.
Hello everyone, my name is Deniz and I will be talking about the diagnostic criteria for non-REM sleep arousal disorders. Firstly, repeated episodes are seen during the first third of the major sleep episode, including either sleepwalking or sleep terrors. In sleepwalking conditions, individuals rise from the bed and walk around with a blank staring face. Waking a sleepwalking individual is very hard. And for sleep terrors again, recurrent episodes are seen. These episodes generally begins with a scream and a cry. Intense fear signs are also observed. The individuals are hard to awaken or comfort. If the individual wakes, there is no stir-like dream recalled, maybe possibly an image from a dream. Both for these subcategories, little to no dream imagery is recalled, and there is amnesia for the episodes. The episodes cause clinically significant distress or impairment in social, occupational, or important areas of functioning. And these conditions are not explained by the effects of a substance such as drugs or any coexisting mental or medical disorders. For sleepwalking subcategory, there are 2 special forms, sleep-related eating and sleep-related sexual behavior. Individuals with sleep-related eating behavior have unwanted eating episodes with varying degrees of amnesia. They may find the evidence of eating episode next morning. And in sleep-related sexual behavior, varying degrees of sexual activity such as masturbation, fondling, or sexual intercourse occur without conscious awareness. There are some disorders may be difficult to differentiate. I will try to mention them briefly. In nightmare disorder, individuals can be easily awakened and recall vivid story-like dreams. In breathing-related sleep disorders, there can be amnesia and confusion arousals, but this disorder is characterized by snoring or breathing pauses. REM sleep behavior disorder can be hard to distinguish from non-REM sleeping disorder. But the main difference is that it occurs during the REM sleep. Also, the individuals are easily awakened due to this condition. Parasomnia overlap syndrome consists of clinical and polysomnographic features of both sleepwalking and REM sleep behavior disorder. Sleep-related seizures can mimic non-REM sleep arousal disorders, but should be classified as a form of epilepsy. Alcohol-induced blackouts can be associated with extremely complex behaviors. However, non-REM sleep behavioral arousal disorders occurs without an effect from a substance such as alcohol. And dissociative amnesia with dissociative fugue can be very difficult to tell apart from non-REM sleep arousal disorder. However, it rises from a period of wakefulness. And malingering or other voluntary behavior occurring during the wakefulness is also arises while the person is awake. In panic disorder, similarly, person wakes from non-REM sleep with fear, but it's a complete awakening, unlike the sleep terrors. Medication-induced complex behaviors can be similar to non-REM sleep arousal disorder, but as I mentioned before, this disorder is not caused by substance effects. And lastly, night eating syndrome differs from sleep-related eating behavior by its association with insomnia or depression. and or depression.
Hello everyone, I am Kerem and I am going to talk about etiology of non-REM sleep arousal disorders. Since finding out the causes is principal for treatments of sleep arousal disorders in general, etiological studies can be said to be of a vital importance for removing symptoms of non-REM sleep arousal disorders. In neurological terms, slow wave sleep is the deepest phase of sleep, and over-experiences of microarousals during that phase is associated with non-REM sleep arousal disorders, specifically with sleepwalking and sleep terror. According to Yaffe and Dorami, genetic tendency underlies most paraphonias like sleepwalking and sleep terror, and they are triggered by alcohol, drugs, and sleep deprivation, as well as some psychological disorders or traumatic experiences. These non-REM sleep arousal disorders are much more common in children compared to adults. That supports the idea that biological maturation of brain has a considerable part of non-REM sleep arousal disorders. As psychological causes, depression and anxiety seem to have a reciprocal causal relation with disorders of non-REM sleep, so that the original cause might be indefinite in some cases. For instance, sometimes being recovered from depression does not result in removal of sexsomnia. Stress and stress-related disorders, on the other hand, seem to be more determined psychological causes of non-REM sleep disorders. In their meta-analysis, German and colleagues indicate that people suffering from post-traumatic stress disorder have reduced slow-wave sleep, which might be an essential mediating factor for PTCD and increasing frequency of having post-traumatic nightmares, sleepwalking, and sleep terror. Even though acute stress disorder is usually associated with sleep comfort and quality, it was asserted that stress-related heart variability might be also responsible for insomnia, some parasomnias, and even sleep mortality in the cases of prolonged sleep latency.
My name is Betül Ayça, and I'm going to continue with the prevalence of non-REM sleep arousal disorders. It's better to consider sleepwalking and sleep terrors separately because sleepwalking is more common in the general population, whereas sleep terror's prevalence is unknown. 10 to 30% of children have at least one episode of sleepwalking, but only 2 to 3% of them sleepwalk often. The numbers peak at 11 to 12 years of age. On the other hand, in adults, it's approximately 4%, but this number is actually higher than the general assumption, and the lifetime prevalence of sleepwalking is 30% according to DSM-5. Also, it is known that little children tend to suffer more from sleep terrors. It can be seen here, 40% in 18 months of age, decreases to 20% in 30 months of age, and in adults, it's approximately 2.2% according to DSM-5. When it comes to their development and course, they may occur in childhood and decrease as aging, and actually it's the most frequent scenario, or it may begin directly in adulthood without a prior childhood non-REM disorder history. And if so, it may be caused by different etiologies, as Kerem mentioned before. They have some risk and prognostic factors. We can divide them into two subcategories. First one is environmental factors, such as medication use, especially sedative hypnotics, neuroleptics drugs, and antihistamines. Also, sleep deprivation, sleep schedule disturbance highly and significantly affect the disorders. On the other hand, physical activity, fatigue, physical and emotional distress also influence the disorder. And febrile illness, especially, fever, especially may induce sleep terrors. Also, it was seen that hormonal factors may affect them as well. Genetic factors, family history, it doesn't matter which one, but family history for sleep terror or sleepwalking, induce sleepwalking up to 80%. Also, sleep terror patients frequently have positive family histories for any kind of non-REM sleep arousal disorders. On the other hand, sleep terror is more prevalent in monozygotic twins than dizygotic twins. On the other hand, another psychological, physiological disorder may cause them as well. It's a nice polysomnography output, which is a device used to measure brain waves during sleep, and you can see directly here the point waves change. This is the point when the patient starts sleepwalking.
Hello everyone, I'm Mustafa and I will talk about treatment of non-rapid eye movement sleep arousal disorder. Okay, let's continue with first precaution. According to the study of Peduk and Perry in 2020, if a person harm himself, herself, or family members, medical treatment can be applied. But the first measures to be taken before it ensuring the safety of the individual and the education of the family. What can we do for first precaution? Items that may harm themselves should be removed from the patient's room. If there is the igniting weapons must be removed from the room. And doors and windows should be locked and door alarm system installed that can alert other members of the family. In addition, family members shouldn't sleep in the same bed with the patients experiencing severe parasomnia. And another treatment type, psychotherapeutic treatment. Hypnosis is a method that is widely used in the type of therapy because it can take effect in a short time and it can be applied both in children and adults. Medicines used in treatment. Many different drugs are used in treatment. Benzodiazepines and antidepressants are the most common used drugs in the treatment of individuals experiencing non-rapid eye movement parasomnias. Clonazepam is also most common used in benzodiazepine class drugs. Imipramine is also one of the most common used drugs in tricyclic antidepressants. Let's look at the specific parasomnias and their treatments. First, I will talk about sleep terror treatments. Benzodiazepine drugs like clonazepam can be used in sleep terror treatments, as well as melatonin or antidepressant drugs. If the patient doesn't have an otolaryngological pathology, the symptoms can be controlled by methods such as midday sleep or night waking. Let's continue with sleepwalking treatment. There are many different methods of treating sleepwalking. First, waking a person 5 to 30 minutes before the hours of sleepwalking parasomnia can be used as a treatment method. If a sleepwalking is not severe enough to harm the individual, there is no need for medication. If the drug is to be used, diazepam or imipramine, one of the three cyclic antidepressants, can be used. But parasomnia is likely to recur if benzodiazepines are discontinued. And lastly, I will talk about confusional arousal treatments. The actions that should be taken first in confusional arousal are to prevent conditions such as excessive fatigue, insomnia, which are the causes that trigger parasomnia. If the attacks experienced by individuals are frequent and severe, drug therapy can be applied. For this purpose, clonazepam from the benzodiazepine class or imipramine and clomipramine, which are the cyclic antidepressants category, can be used in treatment.
So let's move. This study is conducted in Turkey. Our first study is about the sleep problems in Turkish high school adolescents. Researchers aim to investigate the frequency and correlates of a variety of sleep problems in adolescents. As you can see, the sample size is good enough, and nearly 25% of high school adolescents reported that they have sleep problems. And they experience sleepwalking once. The rate is about 3.2, and more than once is about 2.4. And when we look at the night terror rates, it's about 3.6%. And girls had more night terrors in this study, but there was no gender difference for sleepwalking in this sample, you can say. So we have the second study. The researchers surveyed the prevalence of parasomnias in Turkish pre-adolescent children. And the data gathered from 4 different locations. And according to findings, 14.4% of children have at least one parasomnia, which means that every sixth child has at least one parasomnia. And night terror was among the most common parasomnias observed. Rate was higher in 9 and 10 years old age groups, and also there was no gender difference observed. We can say that while the age increases, the likelihood of having parasomnia decreases. And we have the last study here, and in this study, researchers aim to determine the prevalence of insomnia and parasomnia in school children in Trabzon. Again, we have a large sample size and a large age scale from different socioeconomic levels. It's important to note that it is the first study on this issue in Turkey to use large sample size. And when we look at the rates, 4.2 for sleepwalking and 5.7 for night terror. When we compare the all prevalence rates here with the literature findings, it's similar. We can say that it ranges between the reported highest and lowest values. So this brings us to the end of our presentation. We talk about the definition, diagnosis, prevalence, etiology, treatment, and the studies conducted in Turkey about non-REM sleep arousal disorder. And we have reference lists and video references for those who are interested in. Thank you for your attention.